This conference will now be recorded.
Okay, go ahead, Cami.
Thanks. Hi, everyone. Welcome to the next episode of our Framing Rural Health Value webinar series. My name is Cami Norland, and I'm the Community Specialist here at the National Rural Health Resource Center. And we have a fantastic session lined up for you folks today. I'm so pleased to facilitate this conversation as we're going to focus on the value of measuring and monitoring data so we can see how our daily tasks, sort of the humdrum of our days, serve as the building blocks towards meeting the goals we set to accomplish, and ultimately beginning to see those building blocks or metaphorical Legos take form, not just to ourselves and our immediate colleagues, but to our critical access hospitals and our rural communities we serve. So over time, we can begin to see that impact, or altruistic notions of serving the greater good. I think it's about moving from just an idea, a mission, a strategic plan comes into reality. Whether it's our personal goal of ultimately saving patient lives through improving the safety and quality of care, or minimizing chronic disease rates and creating a culture of wellness, or saving the financial vitality of the medical centers in our rural communities. It's this final component in the Blueprint for Performance Excellence that's so powerful and speaks most to me. In all honesty, it's this altruistic notion of striving to create that positive impact that keeps me coming to work every day and making a difference. So this session is of utmost value as we're going to discuss the importance of thinking systemically and utilizing a blueprint to make sense of those building blocks or metaphorical Legos we have strewn about, otherwise known as our daily tasks, and really understanding why and how gathering data can create that impact of improving the health and wealth of our patients, of our hospitals, and of our communities. And we're going to be hearing from Melissa Van Dyne, who's the Director and Flex Coordinator in Missouri, on some of the impactful initiatives that the critical access hospitals in her state are utilizing in response to NBQIP data. And we also have Sue Dietz, Director of the Critical Access Hospital Network for Eastern Washington, on the line to share with us how her network has been gathering some key data points around population health metrics, and they're really starting to see some of those outcomes. So we've got a great lineup for you today. Now, this slide of looking at our current U.S. health outcomes, I know you've all seen this slide before, and so this is no new information, but I use this slide to set the stage for our conversation and just remind us of why we're all working so hard at our jobs to minimize and reduce these undesirable and unsustainable health outcomes, where we want to reverse the trends of having 30 to 40% of all of our medical expense be wasted, where transaction costs consume up to 31% of every healthcare dollar, where hospitals are facing reimbursement pressure from all payers, including their patients, where unsustainable employer insurance premiums are available. And you know, I heard recently a study has just come out estimating that 400,000 people die annually as a result of medical errors across the United States, which is 3 times higher than the original estimation of 100,000 annually. So these numbers are just staggering. Not only that, we see that 75% of medical costs treat preventable chronic illnesses. And of course, there's a long-term decline in our inpatient utilization. But this information is not all lost. There is some hope, or we've got a new business model based on population health principles and practices that drive us towards the triple aim. And so right now we're trying to prepare for the challenge of crossing that shaky bridge from changing our perspective from asking, what's the matter, to what matters to you. Now, before jumping headlong into a population health transformation, health systems must consider why they need to make these changes and what outcomes need to be achieved. So these outcomes are going to vary from state to state and from hospital to hospital, whether a hospital is joining an accountable care organization or establishing itself as a medical home. Each of these are going to have different goals than those that are not participating in these programs. So what does that look like? And because of this variance in how each of our states and communities are so unique, I think we really need to look at some of those overarching concepts of what we've learned from other projects, such as rolling out electronic health records and striving for meaningful use. One of the key concepts that I've taken away from the center's role of serving as the Regional Extension Center for Minnesota and North Dakota is that the HIT transformation was not just about the technology, but it was more about the leadership's ability to strategically prioritize goals, to build that capacity to define success and innovation and prepare staff for embracing change and setting a culture to continuously improve, and also utilizing a framework to standardize and ensure that adoption of new tools and processes. I think most organizations know how to pilot a program successfully, but it's transitioning to a new paradigm, that new business model, or the new way of thinking of asking that question, what's the matter, and going to now asking the question, what matters to you, across an organization. And that what that takes is tools and standards and an organizational structure that embraces change. I read an article yesterday on population health transformation that noted that the challenge of achieving successful implementation and gaining an ROI on elements of population health management cannot be understated enough. Primary care practices looking into achieving their primary care medical home certification can expect to complete 216 separate deliverables of new care delivery and coordination processes. This article indicated that recent effectiveness studies show that primary care practices that adopt the medical home model end up increasing their staffing levels by 59%. If this is done properly, the changes can be profound in helping to improve the quality and operations in the primary care setting. However, if it's done improperly, organizations will simply have gone through a very extensive accreditation process. Which brings me to the point of really reinforcing the value of thinking about our outcomes and the desired impact we aim to achieve, as well as determining what those key triggers of data or actions within our daily work processes are. They're going to move that needle of change so we can build that metaphorical Lego blocks that are being built. A quote I've heard says that if we don't change our direction, we're likely to end up where we're going, which on the national scale, our current U.S. health outcomes, as indicated earlier, leaves us all in a very precarious and unstable healthcare environment. And we know that hospitals are closing out there, and this number is likely to increase, unfortunately. If we view the world through the lens of the bell-shaped curve, we could estimate that 16% of all hospitals, those that are classified in the laggard category, are subject to close, which of course defeats our purpose of all of the work and goals that we're trying to accomplish. So to prepare our hospitals for this transition, I encourage each of us to assist our hospitals in understanding why the big picture. That impact is crucial for future success and helping leadership build that capacity within their organizations to manage this transformation. And one way of doing that is a proven method, as you've heard about through this webinar series, is utilizing a framework such as the Blueprint for Performance Excellence. So as you've heard in previous webinars throughout this series, we've learned about the critical nature of effective leadership and following a strategic plan, followed by the necessity to build a strong, healthy workforce that embraces and protects a positive work environment and culture with internal processes designed with our customers and community in mind. So now that we're looking at what types of data we can gather, what can we learn about the data we collected, and how do we share this information, not just within our leadership teams, but across all of the organizational departments and to our community and customers to indicate that we have the outcomes we set out to achieve and that we have means to justify our value and positive impact in our environment. Here is some great words of wisdom we have heard from some of you folks on the call today that I'd like to share with you, one of which is my favorite and I often reiterate on some of the boards that I participate on is, if you don't have data, mythology wins. So I'm on several boards, and I'm always stressing to them that we need to be able to collect quantitative as well as qualitative data. And some of the reports that I receive back are from the staff that said, oh, everything's fine. Our recent project was a success. And when I ask them to define success and what does that success mean, the response has been, well, because we saw our customers smiling at an event. Now, admittedly, I'm being a bit facetious here, but my point that I keep reinforcing to the leadership is that it's not that I don't trust the qualitative data that they're sharing with me, and I appreciate that the customers were perceived to be happy, but the realist, or maybe the side of me that's kind of a pain in the ass for being a board member, wants to see clarification and definition of why does a smile mean a customer is happy? Could it be that someone else told a joke completely unrelated? How much does the mouth have to curl up in order to be constituted as a smile? How many people were smiling? What was the duration of the smile? I mean, now imagine for a moment if the staff of this organization really tried to answer and measure all of these questions. They'd be going on a really on a wild goose chase of collecting a lot of meaningless data, and what would we learn from that? How would this information support the goals and operations? So perhaps the more important questions to be asking are, if smiling is the right measure to be looking at, how do customer smiles translate into keeping our organization's doors open? Or what processes or staff behaviors need to be replicated and standardized to encourage a customer to smile? Or ultimately, how did the smiling customer endorse our mission? Of course, again, this example is a bit silly, as documenting smiles at an event is unrealistic, but perhaps it gets you thinking about the difference in seeking data that is focused on both output, how many people smiled, to outcomes, how does the smiling customer endorse our mission? Otherwise, the myth that smiles equals success of an event wins, because there's nothing else that tells you differently. So it's really important to take the time to make sure you're measuring the correct data to support your goals and operations. For more information on the distinction between outputs and outcomes, I recommend you check out Task's Evaluation Toolkit, which is available at ruralcenter.org. And this concept is also going to be addressed at the upcoming evaluation workshop, which is going to be held in South Dakota in a couple of weeks. July 22nd, I believe, is the date for that. So once you've determined that you've identified the right data points to be collecting, I can't stress these points enough of using a framework to help organize that data, monitoring that data to see if there are opportunities to improve your actions, or maybe even tweak the data points you're collecting to assure that you're meeting the goals outlined in your strategic plan, or maintaining flexibility within the ever-changing demands of new requirements and policies. So now that you have all of your data driven towards achieving outcomes and you're ready to start crossing that shaky bridge, we've got some strategies to help for translating that data into action. One of which is reinforcing that awareness piece and understanding the why and importance of measuring data. It's going to help you in your transition into the value-based model, as well as making sure that every board member and every staff member and every physician comprehends this concept and is prepared for that change. So you've established that culture. It's about building a guiding team internally to reinforce and support that culture change. It's partnering with the physicians and other providers out in the community, the QIO, the public health department. And because you can't do this alone. It's looking to identifying all of your collaborative stakeholders, whether it's your critical access hospital networks, your state hospital associations, your national organizations and state affiliates, maybe EMS associations, all working together to create that shared vision and strategy with your partners. And maybe there's some opportunities for you to apply for value-based demonstration grants or opportunities for you to really get a project for working together. And identifying where that low-hanging fruit lies, where your team is going to begin to see some of those quick wins and take the time to celebrate those successes, to motivate and reinforce and recognize the value of all of the hard work that's happening. So over time, then anything worthwhile seems to take time, we can begin to see the impact of our efforts. Perseverance is indeed going to be an attribute that will be appreciated on this. So we can begin to see that impact. And a quote here that we've heard from you folks is that we need to highlight ourselves because no one else will. And this is another one of my favorite quotes because I think it rings so true, particularly in rural communities. When I'm out there doing the community health needs assessments and working with hospitals, it's very common that community members are leaving the area for care simply because they're unaware of the local facility providing a particular specialty service because the hospital didn't market it. And frankly, people don't pay attention much to a billboard or something unless they need that service. They're not going to be looking actively for what services are available locally. So it's upon the responsibility of the hospitals to be promoting themselves, and because no one else knows how comprehensive and how patient-centric and how guided your services are towards meeting your mission unless you share that. And people aren't going to know the impact that you have. They aren't going to know that you have the outcomes, that you've achieved the outcomes that you set out to achieve unless you're sharing that. And you're communicating this not only to your board members, to your physicians, to your staff, to your community, and to your stakeholders. This needs to be a continuous loop of communication. If you think back to the slide that we had that outlined all of the 7 Baldrige components, this section of looking at the impact and outcomes, it combines all of those aspects that we have learned to date through all of these webinar series, and it also takes a look at the value of the arrows and how those arrows connecting each of those components is crucial to the success of seeing that ultimate impact and for you achieving your outcomes. Because if we don't document that our value, we're likely to see that some of our hospitals are going to be closing. And so this process of identifying the data and utilizing the data, learning from the data, is crucial for us justifying our value and justifying to all of our key stakeholders that we are indeed following through and accomplishing the objectives and the outcomes that we set out to achieve. So I've got a great panel set up for you folks today. As you waited in much anticipation, I'm thrilled to introduce you to a couple of examples where these concepts that I've just explained are going to be operationalized successfully. And we'll first hear from Melissa Van Dyne, who is the Director and Flex Coordinator for the Missouri Office of Primary Care and Rural Health, where she has established a collaborative relationship with the Missouri Hospital Association and has been working closely with Bryant McNally in particular on developing a process to measure and monitor MBQIP scores, which is a topic that I know all of us are really interested in hearing from. So after we hear from Melissa, we're going to be hearing from Sue Dietz, who has a master's in public health, and she's the director of the Critical Access Hospital Network in Eastern Washington. She earned a master's degree from the University of Illinois in Chicago with an emphasis on community health sciences. And she's got over 15 years of experience in grant development and implementation. And her areas of focus include rural health disparities, health information technology, community-based strategies for chronic disease prevention. And you're going to really see all of how her bio here has played out in the work that she has been doing in the project that she's going to share with us. So with that, I'm going to turn the floor over to Melissa Van Dyne to share with us a little bit about how she's measuring MBQIP scores. Melissa?
Okay. Thank you, Cami. Can you hear me?
Yes, I hear you great.
Okay, great. I'm going to start off by prefacing that I am by no means the subject matter expert when it comes to these reports. However, Bryant, my counterpart at the Hospital Association, is sitting on a tropical beach somewhere, and lucky me, I'm here. So hopefully I'll get through it, but I didn't even want to try to fake it as trying to be the subject matter expert. What I'll start off with is the State Office of Rural Health in Missouri contracts with the Missouri Hospital Association to perform the goals and objectives for the quality improvement section of our Flex grant. The Hospital Association has a very strong and healthy relationship with all of the hospitals here in Missouri, and they hold a lot of clout and are very active, and all the hospitals really look to the Hospital Association for advice and leadership rather than the State Office of Rural Health. So, so we've obviously contracted with them a little over 3 years now. And once Intelligence started releasing the reports for MBQIP, the Hospital Association and a select group of CEOs from critical access hospitals thought it gave it a basic snapshot or sense, but it wasn't information, or it was information that most of them already knew or felt that they should at least know. And they wanted kind of the next step already. And the Hospital Association was actually able to offer that. They own a subsidiary, or there's a subsidiary of the Hospital Association called the Hospital Industry Data Institute, or I'm just going to refer to it as HIDE. And it provides timely access to data and information services for hospitals to support their strategic planning, advocacy, and health policy initiatives. So by using the data system and the analytical capacity that they already had, they were able to create graphic dashboards that show possibly some better or different comparisons for our critical access hospital. So I've got 4 slides, and I'm going to go through them quickly because they kind of show the same stuff. But it will show you what reports could look like for a hospital. So this first one, and I know it's a little blurry, but I can email you ones if it comes out a little bit better. The first one is our MBQIP inpatient measures. And for the purpose of this presentation, we selected all the quarters that there was data available for. A hospital can select whatever quarters or time periods they wish to look at. The top part will look very familiar to you because it should resemble the reports from Telegen. However, the bottom part is something that the Heidi tool will kick out for an individual hospital, and it's used a little bit differently. So when we are dealing with small numbers to begin with, one patient could drastically change the outcome of an overall measure and make our confidence interval huge. So that's actually something Bryant and I talked about as we were kind of going through this presentation, because you'll see on our next graphic slides how that could be a little bit misconstruing. But not only that, when they were looking at the state and even national averages, most of our hospitals were either meeting or exceeding that average. So the last section shows that this particular hospital ranked against other hospitals in Missouri, submitting data through the MBQIP project. So it's just those hospitals that are submitting MBQIP data. The report shows their aggregate rate and also has them ranked overall in the last eight quarters, in the last 4 quarters, and then the most recent quarter. The ranking is where we really have been focusing on when we're talking to our quality improvement coordinators. So for instance, this hospital for inpatient measures HF2 and PN3B is number 1. So they're the best out of the 31 hospitals. However, they're near the bottom for HF1 and PN8 in the most recent quarter. So we want them to ask themselves, so what are they doing that's helping them to achieve good numbers for 2 measures? And then what are they maybe not doing effectively in the other measures? Is it a hospital policy or procedure, or was it possibly a patient-specific, depending on the numbers? And what is the number 1 hospital or number 2 hospital doing that makes them ranked higher than what they are right now? And maybe if they can kind of go back and look at over the quarters how they've increased or improved within a measure, you know, what are some things that they might have instituted that has made them get a little bit better in that measure. So the next slide shows line graphs that can be produced from the reports in Heidi, and it's comparing the individual hospitals to the state and national average for each measure. Hospitals find this useful when talking to their boards or staff meetings for quick visuals, but this is where I'm talking about one patient or one number could really make you drastically decline or incline because our confidence intervals are a little bit small. And then the next 2 slides, I'm going to go through very quickly. It's the same type of data. It's just on outpatient measures instead of inpatient measures. They're not quite as robust because we have not been doing outpatient as long. And we still have some hospitals that are really struggling to submit outpatient data here in Missouri. So those reports aren't quite as robust as the inpatient ones are right now. We've tried doing the same thing with the HCAHPS data, but it doesn't really show anything useful, or not yet anyway. So we don't really have any reports for HCAHPS, and we have not tried phase 3 yet because we're still, again, struggling with outpatient measures. So what this has done is help hospitals look at their data and say, kind of, so what, or what happened. So we do actually have scheduled calls with quality people where they can discuss the measures and how people are addressing improvement around certain measures. We also highlight a hospital during those calls that has improved a measure or who might be the number 1 or number 2 hospital on a certain measure and have them speak as to how they're accomplishing it. We also have statewide meetings and regional meetings once a year, which gives them the opportunity to discuss different strategies. More or less, we're just facilitating the process, but it truly is a peer-to-peer learning opportunity for them. Cammie, that's pretty much it.
Thank you. This is nice to see the graphical form of all of the data that you've gathered. How has this data measurement system you developed improved the outcomes with the critical access hospitals? Is it too early to tell, or have you been able to see any of this impact?
Well, we have had a few hospitals actually take a look at the reports, and again, numbers being very small, they can kind of go back if they, if they only had 3 patients and they missed 1, they can kind of go back and see what happened with that 1 patient. We have had a hospital change a process. It's too early to tell yet because it was just like last quarter, if that change is going to make a difference or not in their overall average, but we're interested to see that. If nothing else, it has opened up during those quarterly calls that they can talk to one another and share ideas with one another, and I think they're gaining, if nothing else, some education, some peer-to-peer education with one another.
Sure. Have you seen any challenges or lessons learned that you'd face in using this model? How has it been for utilizing Heidi?
I can tell you our hospitals like it more than the telegen reports. I haven't had any lessons learned yet. I'm a little bit leery still of some of it just because of the conference intervals being so big, because we're dealing with such little bitty numbers. So I kind of caution them sometimes, especially with these graphs, if they're bringing it to their board, they need to be able to be prepared to discuss why there might be such a big drop, because a graphic visual sometimes might scare someone if it's a huge drop. So I think that's, we've really kind of discussed that here lately, and we're trying to decide if we have enough data to maybe put some standard deviations around some of their data so it would flag it if it were truly statistically significant or not.
Mm-hmm.
But we haven't gotten there yet.
Sure. That would be something that I think a lot of flex coordinators, as well as myself, would be interested in learning about. So if that's, if your processing goes down that way and you're able to determine that statistical significance, we would love to follow up with you and hear more about the outcome of that and what you've learned.
Yeah, we're bouncing that around. We're trying to decide if we have enough yet.
Sure.
Again, the numbers are so little that I don't know if we have enough yet, but we're going to look at it and see.
Yeah, and that might be one of the lessons where it just takes time and perseverance of gathering this data and letting enough quarters pass that we do have large enough numbers then. And it may take a long time, but and I don't know how long that would be, of course, but perseverance might be
right.
helpful with this.
Hey, Cami, it's Nicole.
Yes.
There's a question in the chat box.
Thank you.
You're welcome.
So this is from Stephanie. How do you reflect your data graphically if your hospitals that still show not applicable instead of 0? Do you have an answer for that?
Well, I'll try my best to answer it, but I will definitely ask Bryant to make sure, because I know all of our missing data reflects incomplete data, so it would not be reflected on the charts at all.
Can I, this is Stephanie, can you hear me?
Yeah.
Yes.
Okay. Is it okay to chime in and ask a question, Cami?
Please do, absolutely.
Okay, great, because this has actually been one of the more helpful pieces of all these plenary webinars. So this is exactly what we are trying to do, and we don't have a contract with any kind of an analyst, so I'm actually trying to do this by hand, and this is very, very helpful for me to see how you graphically represent the data. And I think you're always going to have the problem of small numbers, even if you have more hospitals reporting. It's just the nature of the game as far as the way the criteria is for each one of those measures. I don't think that will ever change. But I'm trying very hard to get hospitals to do their population and sampling reports if they're using CART, so that the 0 reflects 0 patients that meet that criteria instead of NA. So even if they were to show 0, because there were no patients that meet the criteria, is that where you're, like for example on the OP1 with the median time to fibrinolysis, is that showing 0 because there were 0 patients? Or is it showing 0 because there was somebody that didn't meet, there was one patient and they didn't meet the criteria, or that they did meet the criteria and they weren't able to do the measure successfully, so that's actually 0% or 0 minutes? Or
it would reflect that there were no patients.
Okay. All right. Well, that's my question, because it, for me, I wanted to try and make sure that it doesn't look like they're actually declining to 0, to try and make sure that if there were 0 patients that met the criteria, it doesn't count against them because they didn't have someone. It would be rather if you had one patient and you weren't able to implement in time or to do what you were supposed to do, then that would actually be the 0. So this is very, very helpful for me. So I really appreciate you taking the time to present this.
Well, no problem. And again, if you have more technical questions, please feel free to send them my way. I may not be able to answer them all because, again, this is the Hospital Association's tool that they developed, but I can get you in contact with the people that would have all the answers.
Hi, this is Scott Daniels in Hawaii, and actually I think the second chart, OP2, is actually a better one to give the example. Does that mean no one made it within 30 minutes, or does that mean there were 0 patients for those 3 cases?
That means that there were 0 patients.
But it could also mean, the way the chart is, that no one made it also. You actually have to sort of know, because right there it's saying 0% as opposed to we couldn't measure it.
Right. And that's, and again, these charts, we just came out with it. I mean, we literally just started doing this probably at the beginning of the year. So we're still tweaking some stuff.
Okay.
This is Stephanie again. Oh, sorry, go ahead.
Well, I was just going to say, this is Joyce in Arizona, and I go with Scott. I mean, what I would see would be helpful is on these charts that you actually have a footnote to define what you just said, because when I read it too, I read it like Scott, and you wouldn't know that it was 0 patients.
And this is Stephanie from Idaho. That's exactly why when I've been doing it by hand, I created these just from scratch, not knowing that anybody else was doing anything similar to this. And I was coming across that problem and I stopped. And I think that this lends itself to a larger question, and maybe it's not in this particular webinar, but I would love to see what other flex coordinators are doing with their MBQuip data to be able to take those Telegen reports and make them more meaningful graphically, because I do think that that is exactly the problem, is having a 0 patient that meets there's 0 patients that meet the criteria versus somebody who actually gets 0%, and having that show up differently. So I would love to have a conversation, a larger conversation about that.
Right. And on those Telegen reports, I think they should be footnoting that. They don't describe it. They don't say what a 0 means or an NA means. And I think that would improve that form.
And I know Bryant and I have discussed this. We would love to see what other flex coordinators or what other flex programs are doing with their data, if they're making things like this, so we can enhance our HIDE analytic tool, if nothing else.
That's great. I agree, and this is a really great conversation to have. I appreciate the feedback from everybody. I see that Carol and Caleb are currently typing questions right now. But looking at, okay, I see that Caleb has come in, where he said that he has created a spreadsheet for each hospital from their data and send that report to them, and they send that out. So we'll keep noting that chat box as we move forward on sake of time. Thank you, Melissa, for sharing all of your work with the MBQuip project. That's a fantastic work. Thank you.
Thank you.
Yeah. Moving on to Sue Dietz with the Critical Access Hospital Network's Rural Health Information Technology Project. Sue, could you share with us a little bit about your project and how you're utilizing data and creating that impact?
Yes, can you hear me?
Yes, just fine.
All right.
Thank you.
I do have a question about moving the slides. I don't see the arrow keys on the bottom.
They are on the left side.
On the
Bottom
left
left.
side. Oh, I just needed to scroll down a little bit. Okay, great.
Yeah.
Well, thank you for the invitation to talk to you today. I'm the director of a Critical Access Hospital Network that's in Eastern Washington. And this is kind of a lay of our land where we are here in Eastern Washington. The circles represent our counties that are in our rural network, and the lines represent kind of their path to get to a tertiary care center and specialty clinic in Spokane. So this group of counties kind of came together with a shared referral pattern that brought them together in 2002 to start some projects, and they were funded to become a rural network with some HRSA dollars. I came on board about 2007 and have been working with them. And one of the reasons I use this map is it does show our HPSAs and our for primary mental health and dental health. And you know, there is clearly need here that they share with limited resources but common problems around rural health disparities. Let me see if I can do this. There we go. So this is who we are. We are 7 public hospital districts. That's how we're organized here in Washington. And a public hospital district is made up of a hospital, a rural hospital. In our case, most of ours are critical access hospitals, as well as the rural health centers, rural health clinics, and if they have a long-term care facility, that would also fall under the public hospital district. So these sites are a great place to test out new ways of delivering care, and because they're all one unit, all the primary care providers and the hospital staff are all under one district. So we've worked together in many projects around sharing resources, capitalizing on our opportunities of joint purchasing, for instance, or collaborative contracting to strengthen our care coordination activities. Like I showed on the map there, care transitions and care coordination is pretty big. Those distances are very large, and as you know, in many of your rural communities, it is essential that care is sought in larger facilities, tertiary centers, and specialty care, and to get that information back and forth has been a highlight of a lot of our activity. Today I'm going to talk, though, about the latter 2 bullets here on this slide, and that is around health information, technology, and data. One of the first things that happened at my interview in 2007 was 6 CEOs looking me in the eye and saying, we want access to our data. These folks have EMRs. They have disparate EMRs. Some are on Practice Partners, some are on Centricity, some are hosted by a larger data facility within the Spokane region, some are independent. They're all kind of organized different, but they all have had access, and they are quite progressive in terms of achieving meaningful use, for instance, or staying readily current with information technology the best they can with limited budgets, of course, but that's where I come in as a grant writer. Oftentimes I'm the one that's kind of piecemealing things together to support their activities. This slide here talks a bit about why our need is presented. As I showed on the first slide with the map that indicated our HIP says, you know, that's just one piece of the pie. The rural disparities are, you know, around age. This is a very elderly population. 20% or higher. They are needing, are in that age demographic of 65 or over. They have high rates of diabetes, high rates of chronic heart disease and obesity, cholesterol, when you compare to the state average, and even when compared to Spokane. So these programs are very, it's very clear to see need. So we started some projects collaboratively around the patient-centered medical home. You know, back in 2007, it wasn't called the patient-centered medical home. I think it was just the medical home, and at that point, the recognition wasn't even on our radar as an activity. But we were starting to organize ourselves on what tools can we use to address our chronic disease management, to address our care coordination activities. And that, of course, brought us to telehealth services, as well as, most recently, a lot of behavioral health and primary care integration work. We work as county coalitions, kind of was brought up on earlier today, the presentation, as the stakeholders of the county is not just a primary care provider, it's a behavioral health, it's the school districts, it's the county commissioners. It's really getting everyone on board, and oftentimes what's required to have those conversations and really strategically move forward as a region or a county or as a facility is the access to data. Comes full circle to my interview, right? We want access to our own data. This population health measurement has been key for all of these activities, and it's been essential for the patient-centered medical home in 2012 now. It was a February board meeting, and my board agreed that all of our sites would move towards patient-centered medical home level 1 recognition, and Sue Dietz would support it. So I was put on task to, wow, that is a big undertaking, and what is that going to look like, and let's do it together, and let's share policies, and let's go through the audit and enrollment period together. And so we're in the middle of that, and part of that was instrumental to that was a recent HRSA grant that we got that I'm going to talk to you about here today. So as I mentioned earlier, we all had EMRs, and we all had access to reporting. I mean, they have some CAN reporting in Allscripts or CAN reporting in Centricity, or at the time, even one of ours had Soapware, which is quite antiquated, and they had some flow charts, but not a lot of access to data. It was a lot of Excel spreadsheets, to be quite honestly, on how we were measuring our data. And so I wrote a grant to the Rural Health Information Technology Network Development Grant Program and said, you know what, I'm really interested in creating a disease registry, or using, excuse me, not creating, at the time it wasn't creating, but purchasing a disease registry that links to their EMR, so it maps to their own individual EMRs. And then I want to take this data, this is kind of the pie in the sky grant, I want to take that data and I want to de-identify it, and I want to throw it into a central data repository so that I can look at that, our network on a regional, what's happening in eastern Washington. I want to be able to compare, you know, Lincoln County to Pend Oreille County to Garfield County. Where are their differences? Why do they exist? And really start diving into this, where I'm not just using county ranking data, for instance, because oftentimes those service areas are very different than the whole county per se. So that's, HRSA gave us the award in 2011, and we're just closing up here on 2014, and August 31st is our last day. And this architecture that's presented on this slide kind of says what we've created. We did a mini HIE that has a central data repository, and while this is quite a techie slide, what this is telling you that each of these hospital districts has a disease registry that is then linked to a central data repository. And this next slide is going to show you what that really looks like. Okay, so These are two of the tools that we use. The one on the right we purchased, and the one on the left we worked very hard over the past 3 years to create. The one on the left is a population health tool that gets actually, it's generated based on scheduling. It is printed every day by a vendor that prints off in each of the clinics based on who's coming in for an appointment. And this is very patient-specific information, and it will say, you know, this is the patient coming in, here's their demographic information, these are all their diagnosis codes, this is why they're here. Just kind of a cue for the provider and the MA to room the patient around evidence-based guidelines. So this person, you know, here this trends their BMI, or it will trend their Framingham score, or it will alert them of an immunization that might be required or recommended, excuse me. And so it's actually quite a versatile tool in that the provider can decide what's in each of those little boxes. So we work with a vendor to identify a tool that works for them. And this is actually a lot of the data. So this is individual data. This is patient data. This isn't population health data. But this data is, one reason I show it to you is it helps with the quality of, you know, garbage in and garbage out. If you don't have good EMR data, then you don't have good population health data. So we do a lot of data cleaning. You know, you might look in the diagnostics and say, you know, this isn't correct, or they haven't been on this medication for a very long time, or because medication reconciliation can happen here. And so it's helped with our quality of our data. And then while we bought this, we really wanted to get to the disease registry data that starts looking at the population health. And the vendor said, which this will probably get to the question of whatever my challenge is, the back of the box said that they have a disease registry. It maps very simply with interfaces, and in the case that wasn't true. And we had to find another vendor to help us create something. But there was a jewel in there. It was suffering at the time, but was where we got to create whatever product would really work the best for our organizations and was current and wasn't based on crystal reports. And it was very iPad-ish and intuitive. And so we created the tool on the left. And the vendor's Pradex, who helped us do this, and they that's live data for a population. You can also look at it by the individual. In the case of this, one of those green bars, if I were to scroll over that green bar, and this was, let's say this is an A1C for diabetics, and that's the range of the outcomes. This tallest green bar, let's say I put my cursor over it, I can find every single patient with their telephone number, the last time they were in, all the information I would need to generate a recall list, for instance, if that was a bar of concern. So all of a sudden I have this very user-friendly chronic disease management tool. I can generate reports out of this. I can create my own dashboards. I can look at a whole series and spectrum of disease processes on this on a local level as well as a regional level. And here's an example of the measures that are included to date, and this is still growing. And then I can sort that by age, gender, demographics, you know, the location. Am I looking at Lincoln County? Am I looking at Garfield County? And I can also sort by provider all the way. The providers, there was a little bit of issues around buy-in, but we're getting there. As long as they know the data is valid, then the competition starts. And so we've been working very closely with the providers all the way through this project to make sure that they feel that this is not evaluating them, but supporting their work. We can identify benchmarks that we want to use or not. There is always some questions around benchmarking, what is applicable to the rural population. We can identify timeframes and payers. And so To say the least, I know that we're getting close on time, so I'll speed it up here. The goal is now the so what. I have been, just to get that thing working has taken 3 years. It blew your hair back. It's great, and we're doing a lot of demos across the state, and actually I've done some demos with your organization, with HRSA, as well as a National Rural Health Resource Center, and I'm trying to show people this is here and it's affordable. And I don't have any vested interest, honestly. I don't have any shares in the company. I kind of wish I did, but I don't. And now I'm working with an evaluator. We're working with Group Health Research Institute out here in Seattle, Washington. And they've watched the evolution of this project, and now it's starting to dive in. Okay, so what does this mean for readmissions? What does it do to our ED visits? Are the providers happy with it? Is it actually improving costs as well as a triple aim? So what does all that look like? We're still unfolding that due to the delays of rolling out the product, where we thought we could just turn it on instead of create it. We're a little bit behind on the evaluation part, but we're live now, and that's a pretty exciting place to be for the research end. And so we've also been close with UW to support a lot of this work. And so with that, I guess, given that we have 5 minutes left, I'll quit talking. But if you'd like further information, I'm happy to share it with you.
Great. Thank you so much, Sue. This is fascinating information. And what item that stands out the most to me is that you're able to dive in on that green chart, bar chart that you showed, and you could see the individual patients along with their contact information. Talk about
the demo is amazing. It is. Yeah. It's a lot of fun. I'll be totally honest with you. I feel like a child, or like I burst something so exciting. And so I see one of the questions around our state health department. This is local data. The state health department is actually looking really closely at this tool to support some state initiatives that are currently underway. And so we'll see where all that goes. But we're happy to share it with other rural health or networks on the state as well.
Fantastic. Thank you so much. And we've got a question here from Jill Bullock, who is wondering if you know of other state health departments that are utilizing this tool.
No. I honestly, I've had a hard time finding a vendor who had the analytics to support a tool with disparate health EMRs. There might be a vendor that creates it, but it's only for centricity, for instance. It's not where I can apply the same thing to all scripts and the same thing to. So I haven't, I'm not saying it's not out there. I just, in our initial search 3 years ago, it wasn't there for our needs.
Sure. Well, thank you so much. This has been a fantastic tool, and I'd love to dive in myself and do some exploring. Is there a way that we could do that? Is there a demo that's available for?
Yeah, we can work offline, and I can hook you up with a demo for that. And if you want to open it up for others to see, I'm sure that it would be a very welcomed request.
Awesome. Well, thank you so much, Sue. We really appreciate you sharing this project and how you've been able to take some data and create some demonstratable outcomes. Thank you for preparing your presentation. It's been much appreciated. So looking at what does all of this mean? I think one of the bottom lines here is that critical success factor of sharing information, of establishing that leadership ability to strategically prioritize goals, looking at a framework, and preparing folks for that culture change. But then, not only that, but sharing all of this information. And I've been reading the chat on the left column of the screen here, just scrolling up of all of these wonderful suggestions and of folks sharing what they're doing with their projects and wanting to really share this information and learn more. And so that's certainly something that TASC as well as the Federal Office of Rural Health Policy will be looking into. And we appreciate all of you folks for your collaborative spirit and sharing this information as well. Looking ahead at our